for hopping on this morning. My name is Katie Best. As Bien said, I am the Assistant Director of Sports Nutrition at Wake Forest University. So today I'm going to be talking to you about 10 principles of nutrition for recovery and performance. So we know that nutrition is an essential part of performance and recovery in a multitude of ways. So I'm hoping that by the end of this presentation today, you'll have a basic understanding of how nutrition impacts an athlete's health and performance. You'll understand signs, symptoms, and risk factors for relative energy deficiency in sport, or REDS, which we'll talk about, and eating disorders. And you'll understand situations warranting a referral to a sports dietitian. Oops. So the topics for this presentation today, the 10 points we're going to cover are macronutrients, energy availability, eating disorders, hydration, alcohol, supplements, fad diets, weight management and body composition, recovery nutrition, and injury nutrition. So this is really meant to be a high-level overview of each of these topics. Each one of these could probably be their own nutrition presentation. But my goal today is to give you an overview and an introductory understanding of each of them and how they affect recovery and performance. They will not align exactly with the themes that were presented in the article that VN sent out. There's a lot of overlap with them, but some of those themes were specific to more particular populations, and I felt that providing a broader level overview would be more beneficial. So beginning with our first topic, macronutrients. Three main categories of macronutrients. You may have seen this before, but we're going to start with the basics. So carbohydrate, protein, and fat. And the exceptions to this are water and alcohol. Every food falls into one or multiple of those categories except water or alcohol. They're each their own category, and we'll talk a little bit about how hydration and alcohol affect performance. So beginning with carbohydrate, it's stored as glycogen in the muscles and liver. We get about 300 to 400 grams of carbohydrate stored as muscle glycogen and about 75 to 100 grams stored as liver glycogen. So those amounts vary widely depending on the person, depending on the body size, but that's about a ballpark. We also have some circulating throughout the body in the form of blood glucose. That's about 5 grams. So carbohydrates are the body and brain's preferred fuel source. We preferentially metabolize them. They're critical for intermittent high-intensity activities and prolonged endurance activities. And so muscle glycogen and blood glucose provide about half the energy for moderate intensity exercise, so that'd be at about 65% VO2 max, and about 2/3 the energy for high-intensity exercise, which would be at 85% VO2 max. We recommend that athletes consume carbohydrates before, during, depending on the activity length and intensity, and after exercise. So before exercise, if it's far enough out from their physical activity, it's going to be topping off those muscle and liver glycogen stores, so tucking a couple hours out here. If it's within, say, an hour or so, it's going to be providing increased carbohydrate availability in the blood. During exercise, again, this is dependent on the activity length and intensity. For activity less than an hour, we wouldn't normally recommend that athletes consume carbohydrate, but it provides increased carbohydrate availability, often in the form of easily digestible and readily available carbohydrates. So those are your things like sports drinks, chews, you could do even like a banana or something like that. And then, of course, after exercise, we want to replenish the lost muscle and liver glycogen stores, so carbohydrate is essential then. Long-term inadequacies can really negatively impact immunity and also cause muscle protein breakdown. We'll talk a little bit more about why it causes muscle protein breakdown later on in the presentation. And carbohydrate recommendations vary pretty widely based on the athlete. So anywhere between 3 and 12 grams per kilogram of carbohydrate could be appropriate for the athlete. And that's based on a bunch of different factors like weight, training intensity, the length of their activity, their total energy needs, and then also their specific nutrition goals as well. And then some examples there you may recognize: grains, dairy, beans, vegetables, fruit, and then your sports foods. So the second macronutrient is protein. It's the building block for muscles, other tissues, enzymes, hormones, and antibodies. And they're made of amino acids. So we have 9 essential amino acids that cannot be made within the body that we have to get through the diet, and 11 essential amino acids that can be made in the body. So whenever we talk about protein, we typically hear it emphasized in the sense of post-exercise, so immediately following that bout of physical activity to help promote muscle protein synthesis and repair. But initially it was thought that within an hour after physical activity was essential in order to promote maximum muscle protein synthesis. But we see now in the research that while that's beneficial, muscle protein synthesis continues far beyond 1 hour after physical activity. So if we can get protein in that 1 hour following it, that's great, but it's not essential. It's more about the overall daily protein consumption and making sure that's spread out throughout the day. So to achieve that, we would have the athlete have a source of protein with each meal and snack, and that generally covers their increased needs. So needs similar to carbohydrate are based on weight, energy needs, nutrition goals, and training demands. And some examples there, of course, your animal proteins and dairy, beans and legumes, soy products for vegetarian sources of protein. And then we have nuts and whole grains also provide a little bit of protein. So the third macronutrient is fat. It maintains our body temperature, supports immune functions, visceral fat cushions our organs, it facilitates nerve transmission, helps with vitamin absorption. There are 4 vitamins, vitamins A, D, E, and K, that are considered fat-soluble vitamins. And so they can only be absorbed if there's an adequate amount of dietary fat in our diets. So that's definitely important for that micronutrient absorption. And then, of course, it provides a long-term energy source. There are 2 types of fat. We have our unsaturated and our saturated fat. So unsaturated, you may have heard of referred to as heart healthy. And that includes plant oils like olive oil, canola oil, peanut oil, nuts and seeds, avocados, fatty fish, some omega-3 eggs. And then you have your saturated fats, which may cause heart conditions and inflammation. Those include more of your animal sources of protein, dairy, fatty or processed meats like bacon, sausage, fried foods, commercial baked goods, and snack foods. And then I like to point out that coconut oil is also a saturated fat. So although plant-based fats tend to be unsaturated, coconut oil is an exception. It is a saturated fat. I know that's becoming more popular and kind of more in the media, so just like to take a chance to note that. So typically fats end up being about 20 to 35% of the total calorie intake. That's what's recommended in order to support athletes, because if you're having too little fat, that can not only lead to low energy and the poor nutrient absorption, but also lead to decreased immunity and oligo or amenorrhea if we're not meeting calorie needs. And then, of course, on the flip side of that, too much fat can lead to an inadequate consumption of other nutrients, can also cause weight gain or cardiovascular conditions. So moving on to energy availability. So what is energy availability? It's the balance between our energy intake and our energy output. So energy intake is the calories that we're consuming, what we're eating in our diet every day. And energy output is our energy expenditure. So our resting metabolic rate, our physical activity, and then our activities of daily living. So whenever energy intake is less than output, we end up in an energy deficit, often losing weight, but not necessarily. Whenever intake is equal to output, we have what's called energy balance. And then if intake is greater than output, we have an energy surplus, which can result in weight gain. So this is often referred to in terms of kilocalories per kilogram of fat-free mass. Since obviously different athletes are eating different amount of calories, we can't say one certain amount of calories gets you to energy balance. But typically in healthy adults, more than 45 kilocalories per kilogram of fat-free mass is energy balance. If they're in the 30 to 45 range, that's considered reduced energy availability. And you could see some subclinical symptoms there, or you may not. And then under 30 is considered low energy availability. And so we'll talk about what that means now. Low energy availability, it can be intentional or unintentional, but essentially we're not getting enough calories for our body's needs. It can be related to an eating disorder or disordered eating behaviors, but it doesn't have to be. And other factors to consider that could possibly contribute to this would be nutrition knowledge and skills. If the athlete just doesn't know how many calories that they need, or maybe they're not able to cook for themselves. Food access, socioeconomic status, recent illness, psychological factors. So there are plenty of things that can play into this. You may have heard of low energy availability in the context of the female athlete triad. So you might have seen the graphic over on the right there. That's often how it's referred to. So you see the green triangle. We have kind of our optimal performance. So optimal energy availability, we're eumenoric, and optimal bone health. And then we have a blue spectrum leading down with reduced energy availability. Again, that's a lot of subclinical manifestations, including subclinical menstrual problems and lowered bone mineral density. And then the red triangle, we have what was referred to as female athlete triad. So low energy availability, again, with or without an eating disorder. We have functional hypothalamic amenorrhea and osteoporosis. And so the female athlete triad is that cluster of 3 symptoms in the red triangle, and they're detrimental to performance. So as research has evolved, it's become apparent that this isn't just a cluster of 3 symptoms though. Low energy availability has wide-ranging effects on many areas of health and performance. And it's also seen in men. So calling it the female athlete triad is not really appropriate for addressing and recognizing this condition in all athletes. So in 2014, the IOC introduced the concept of relative energy deficiency in sport, and it provides a more comprehensive term in place of the female athlete triad. So if there is one thing that you take away from this presentation, let it be these slides on REDS. So basically this term highlights the increased complexity compared to female athlete triad and also includes males, but still the root cause of it is energy deficiency. So if you look at the 2 wheels down here where it says REDS in the middle, that is low energy availability, and it leads to all these other problems. So on the left, looking at the body systems, we can see it affects just about everywhere. You see that the female athlete triad is still represented there between low energy availability, menstrual function, and bone health, but then we have added in all these other areas that low energy availability can affect. So from a metabolic standpoint, we see a decreased resting metabolic rate. Hematologically, we often see anemia. From a growth and development standpoint, that can be slowed, and sometimes the athlete's able to catch up, but sometimes they're not, depending on what phase of growth and development they're in. Cardiovascularly, we see endothelial changes and also hormone changes that lead to early atherosclerosis. Poor lipid profiles, we can see severe bradycardia and then also arrhythmias. From a GI standpoint, we see delayed gastric emptying, constipation, and altered sphincter function. And then we see that immunity is decreased and we have an increased rate of upper respiratory infections. So then on the right, you see some additional outcomes that are potentially more related to performance in the traditional sense. So decreased muscle strength, glycogen stores, depression, irritability, decreased concentration, decreased coordination, etc. So obviously all these affect performance. And the last point I'd like to make on this slide is if you look back over to the left-hand side that's looking at the body systems, you'll see that all of the arrows are single-headed except for the one between psychological and low energy availability. And that's important to consider because not only can low energy availability trigger some psychological problems, but it can also be the reverse. So if you think about an athlete that may be having a mental health crisis, they may be struggling or unable to feed themselves because of that crisis. So it's important to consider that that can go both ways. So risk factors for REDS include injuries and illness, because athletes can develop a fear of unwanted weight gain. Decreased performance from a loss of lean body mass is another risk factor. Promotion of nutrition myths, diet culture, or misinformation from a variety of sources. A lot of times these people are well-meaning, but we'll talk about fad diets in a little bit. This information can be incredibly harmful and put the athlete at a higher risk for low energy availability. Again, the lack of nutrition knowledge or skills, the athlete may not realize that they're underfueling. And then personality traits also can play a role in this. So perfectionism, competitiveness, and ability to train through pain, which incidentally are 3 characteristics that many successful athletes possess. And then sports with an emphasis on leanness or aesthetic, judge sports, weight class sports, any sport with a need to make or cut weight, and then anything where a uniform may be a little bit more revealing. Those can also predispose an athlete to REDS. So what do we do about this? From a screening, assessment, and treatment point, it can be challenging because symptoms are often subtle and subclinical. We may not see a full manifestation of them. On top of that, many screening tools exclude male athletes, differently abled athletes, and non-white athletes. So we're really not able to accurately track this in a lot of populations. But early detection is critical in preventing long-term health consequences. So the IOC recommends screening at a multitude of time points. So not only as part of the annual health examination, but also anytime an athlete presents with an eating disorder, weight loss, lack of normal growth or development, menstrual dysfunction, recurrent injuries and illnesses, decreased performance, and mood changes. And the menstrual dysfunction is something I'd really like to highlight, because I think a lot of athletes, if they lose their menstrual cycle, they perceive that as normal or just part of sports. But that's something for us to really be on the lookout for as sports performance professionals, because that can be a very good indicator of energy availability. It's usually the first thing to go. So screening tools exist, but they're not validated. And again, as I said, they aren't necessarily applicable to all the populations that we're working with. And so your role is to be aware of the symptoms of REDS and refer to appropriate sources. So for an athlete to come to a dietitian about this, we either have to already be working with them and have identified it ourselves. They have to have identified that there may be a nutrition problem and come to us. Sometimes that happens in the case of fatigue, but not always. And sometimes we're able to identify it during like a body composition assessment, but usually by then it's quite progressed. So we need your help identifying at-risk athletes. You guys are working with them hands-on almost every single day, if not every day. You get a lot more FaceTime with them, and you are working with largely most of the people on those teams. So we really, really need your help in order to identify this and keep our athletes' health and safety as a #1 priority. So looking into eating disorders now. Eating disorders can have both short and long-term effects on health and performance. So things like dehydration and electrolyte imbalance, which can lead to more severe like cardiovascular problems, things like depression. And it's estimated to affect about 25% of female college athletes and 20% of male college athletes. So that's across all sports. And there can be a multitude of reasons for an increased risk. So it could be the stress of transitioning to college. Again, critical comments from coaches or parents, judges, teammates, depending on what the team culture is, that may be more common. High academic demands, causing them to feel like they need some kind of control over something, and stress of losing scholarship or financial aid, and of course the pressure related to aesthetically driven sports. So amenorrhea, or loss of a menstrual cycle, is one of the characteristics of many eating disorders, so it doesn't have to necessarily present. There's a pretty wide variation in estimates of menstrual disorders in athletes. But it's thought that primary amenorrhea, or absence of a period starting ever by 15 years old, is about 7% in female college athletes, but we see that it's higher depending on the specific sport or activity that you're looking at. So we see 22% in cheerleading, diving, and gymnastics, those more aesthetically driven judge sports. And then secondary amenorrhea, the absence of 3 consecutive cycles, is estimated at about between 2 and 5% in female college athletes. But again, we see that it's much higher in certain populations. So 69% in dancers and 65% in long distance runners. There are a couple different causes for this. It could be abnormal hormone levels. It could be inadequate body fat stores. Both of those could be related to low energy availability. And then, of course, exercise stress. But we see that from a low energy availability standpoint, this happens because luteinizing hormone pulsatility is disrupted, and that decreases gonadotropin releasing hormone. So it really comes down to the hormone cascade. Osteoporosis is a second condition that's often associated with eating disorders. So from a bone mineral density standpoint, that peaks at around 19 for women and 20 for men. And this is something that once we only have a certain amount of time that we can establish bone mineral density, and once we've passed our early 20s, we are not able to establish more bone mineral density. So we're either maintaining or losing for the rest of our lives. And so this can be measured, bone mineral density can be measured in a whole body DEXA scan. Athletes in weight-bearing sports typically have a bone mineral density that's 5 to 15% higher than non-athletes. So one of the benefits of doing a weight-bearing sport. And whenever we're looking at this, a Z-score between -1 and 2 is considered low bone mineral density, and then anything less than -2 would be considered osteoporosis. So as we're doing body composition assessments, we can be aware of this, and then also looking for things like recurring stress fractures could be a sign of low bone mineral density. So other implications on health and performance for eating disorders. So in the short term, we see reduced muscle protein synthesis, glucose utilization, and fat store mobilization. So all 3 of our macronutrients are affected here. We see a decreased hormone production and a slowed metabolic rate, reduced immunity, and reduced responsiveness to training and recovery. And then in the long term, we see things like anemia, other nutrient deficiencies, fatigue, psychological stress and depression, eating disorders, endothelial dysfunction, again, the bone mineral density, and altered hormones. And so this doesn't include the things that we talked about on the red slide. So the other potential adverse effects from low energy availability, add those in on top of this. And so you can see that it's critical to be aware of some of the signs and symptoms of eating disorders. So moving on to hydration. Water is important for maintaining the moisture in our mucous membranes, thermoregulation, sweating, joint lubrication, nutrient transport, and as well as oxygen and waste transport. And optimal hydration requires both fluid and electrolyte balance, and going into exercise hydrated helps ensure optimal physiological and performance responses. Our muscles are about 75% water, so if we're going in dehydrated, that can obviously cause some problems. So electrolytes are helping with cell function and help the body hold on to water, and electrolytes are lost in urine and sweat and need to be replenished. So studies show that about 50 to 60% of college athletes enter practice with a urine-specific gravity that indicates hydration or dehydration. So monitoring hydration status can be really important, whether you're doing that using urine-specific gravity or using a chart like on the right, which can be a little less time-consuming and cheaper. So I often tell our athletes, if your urine is like lemonade or lighter, you're appropriately hydrated. If it looks like apple juice or beer, we got some work to do. So it's important to be aware of that because Armstrong found that a loss of just 2% of body weight decreased running speeds by 6 to 7% in the 5,000, 10,000 meter races. So obviously that's enough to change the outcome of an event. And that's also important because our thirst response doesn't really trigger until about a 2% loss of body weight. So, and then beyond that, thirst is not a reliable indicator of hydration status. So one, athletes can be distracted while they're training, which means they might not even pick up on their thirst response. It's also often mistaken for a hunger response. And then secondly, fluid might not be readily available. So depending on how that particular team runs practices, thirst might be recognized, but it might not be convenient to stop and rehydrate. So warm climates can exacerbate this. A study of Puerto Rican soccer players found that they had less body water at the end of a week where they were drinking freely versus when they were required to drink about 4.5 liters a day. And so we see that consumption frequently doesn't match losses. That can make it hard to gain or maintain weight, and it also puts athletes at risk for injury or decreased performance. So water alone is not effective for rehydration. It causes plasma osmolality to decrease, which suppresses thirst and increases urine output. So we need those electrolytes in order to effectively hold on to that water. Looking at alcohol, 2017 NCAA National Study of Substance Use Habits of College Student Athletes found that 70% of athletes reported drinking alcohol in the last year. And that's actually down from previous years and comparable to drinking rates in non-athletes. About 42% of student athletes said that they binge drink, so that's classified as 4 or more standard drinks for women in one sitting and 5 or more standard drinks in one sitting for men. You can see what a standard drink is down there at the bottom. And nearly 60% of student athletes believe that alcohol has no effect on their athletic performance or general health. So we know a little bit better than that, though. These are the effects that alcohol has on performance. So from a hydration standpoint, we know that it's a diuretic, causes dehydration, it weakens the pumping of the heart, impairs thermoregulation, and increases fatigue. Motor skills affects just about every aspect of that. Reaction time, precision, equilibrium, coordination, accuracy, etc. Strength, power, and performance, again, affecting each one of those factors, decreased strength, sprint performance, grip and jump height, faster time to fatigue. From a recovery standpoint, we see that it's a poor source of nutrients. It doesn't provide any kind of micronutrients, fiber. It, as I said before, is not considered one of the 3 main macronutrients, and it may replace nutrient-dense calories. So especially if an athlete is doing something like saving calories for drinking, we see that we're losing a lot of beneficial nutrients in that loss of calories, which is being substituted for nutrient-dense calories, or excuse me, nutrient-free calories. Risk of illness and injury, obviously an increased risk of injury, decreased immune function, and delayed healing. And then from a body composition and weight management standpoint, we may see weight gain because of how ethanol is metabolized. It's metabolized as like a fat or a fatty acid. And then additionally, after a night of drinking, athletes may not be making the best performance food choices, which can contribute to weight gain. And then, of course, heavy chronic consumption can lead to nutritional deficiencies, altered digestion and absorption and metabolism. And so these effects last longer than just like a hangover. They can be up to 72 hours after consumption of alcohol. So it's not necessarily just a day after problem. This is potentially up to 3 days after alcohol consumption. Supplements. So supplements really run the gamut here. It includes a variety of things like vitamins, minerals, herbal supplements, protein powders, pre-workout, you name it. So in determining whether or not something is a supplement or a food, we can look at the back label on it. If it says nutrition facts, it's considered a food regulated by the USDA, FDA. If it says supplement facts, there's essentially no regulation on it. So there's a wide variety of products available, all with varying levels of efficacy and safety, but none of them are regulated in the United States. So we have to rely on third-party verifications for safety. This is obviously a huge concern across all levels of athletics. not only are we wanting to avoid positive drug tests, but again, athlete health and safety as the first and foremost thing that we're concerned about. So many can offer benefits to performance, but they also may not. So some of them can be helpful in providing key nutrients. If we think about like a protein powder, like a gainer shake or something like that, that may be providing beneficial nutrients to athletes. Things like vitamin D, iron, those kind of things also can supplement nutritional deficiencies, but plenty of supplements do not provide any benefits. So things to consider whenever looking at a new supplement, 3 questions that we want to ask. So is it safe, not only from an ingredient standpoint, but a manufacturer reputability, appropriate dosage, possible negative side effects or health outcomes? Is it legal? So not only within the country, but within sport. Is it on an NCAA banned or impermissible substance list or the WADA lists? Is it effective? So is there evidence that points to any kind of benefit? Or is there another way, potentially without a supplement, that you could achieve the same results with less risk? So all important things to consider. Any athlete that is wanting to start using a supplement or already using a supplement should have it cleared with a sports dietitian, team doctor, athletic trainer, etc. So the Australian Institute of Sport developed an evidence ranking framework to categorize supplements and ranks them from A, which is the best, to D, the worst. A and B are supported for use in specific situations and then deserving of further research, but like recognized as safe. Whereas C is little to no evidence of efficacy, and D is banned or high risk of contamination with substances that could cause a positive drug test. So you can see each of the supplements that are listed in those categories, but just because they're supported in literature as effective doesn't mean that they're allowed. So supported in the literature doesn't mean that they're not on an NCAA list. So for example, caffeine is on the NCAA impermissible substance list. So athletes can use it, but it's only allowed up to a certain urine concentration, and it can't be provided by the institution. It would have to be something that the athlete took themselves. So we can't give them a pre-workout protein powder that has caffeine in it. And then of course the NCAA also prohibits supplementation with individual amino acids is another example. So like beta alanine or BCAAs would not be something that we could give to athletes. So they can take them on their own, but the institutions can't provide them. And again, just because they're proven effective doesn't mean that that particular brand or product isn't contaminated. So overall, we want to take a food first approach. Supplements are not necessary for success. And they can be helpful, but they also can be detrimental and potentially dangerous. So we have to always consider, is the risk worth it? Utilize reliable third-party verifications like the NSF for Sport, or there are plenty of other ones out there as well. And if it sounds too good to be true, it probably is. So keep that in mind. Looking at fad diets, this includes diets like paleo, keto, whole30, intermittent fasting, gluten-free, raw veganism, carnivore diet, fruitarian, Atkins. Basically, if you've seen it on a magazine cover or you've heard an Instagram influencer talk about it, it's probably a fad diet. It's any diet that intentionally eliminates food groups or eats one type of food to excess. And they're often very rule-based. Like you can have this thing, you can't have this thing. You can only eat during these times, that kind of mentality. So the intent is often rapid weight loss, and it's not sustainable and it can be very unsafe. They're all successful for the same reason. I say successful in quotes because again, not sustainable and can be unsafe. But in cutting out food groups, the calories that we're consuming end up less than the calories that we're expending. That's the bottom line. So all of those and many others are things to be aware of. If you hear an athlete talking about them, send them to a registered dietitian. So the problem with these diets are that they eliminate essential food groups and nutrients. So something like the keto diet with heavy emphasis on fats and total reduction of carbohydrate sources would be an example there. It often results in a quick reduction of weight, which can also lead to a loss of muscle mass. So as we were talking about in the protein section, the body doesn't, whenever we're in a calorie deficit and we don't have adequate carbohydrate stores, the body doesn't preferentially metabolize only fat. If we're out of muscle glycogen, liver glycogen, and blood glucose, our body doesn't just start metabolizing exclusively fat stores. They metabolize some fat stores, but they also are going to take protein because protein is easier to metabolize than fat. So we see that as a loss of muscle mass. And again, not sustainable in the long run. This research frequently shows that the weight loss is temporary and that individuals who partake in these diets will regain the weight, and often possibly more than they initially were before they started the diet. And then severe food restriction can, of course, open people up to an increased risk of binge eating and other disordered eating behaviors. So the research consistently shows us that there's not a single fad diet out there that produces long-term weight loss. Many of them are also not approved for performance improvements. Of all the ones that I listed on the previous page, not a single one of them is beneficial to athletic performance. And so another thing to consider when we're thinking about this, is it about the foods that we're removing or is it about the foods that we're adding? So if someone's cutting out an entire food group, oftentimes that ends up being a lot of like the more processed kind of junky foods. So are we seeing benefits because we're cutting that out, or are we seeing benefits because we're adding in a lot of fruits and vegetables and whole grains and fiber and that kind of stuff? So I think people often attribute it to the foods that they're cutting out, but in reality, it can be a lot from what the foods that a lot of benefits from the foods that they're adding. But again, if you hear an athlete talking about any kind of fad diet, send them to a dietitian. Weight management and body composition. So a lot of athletes look for changes in their weight to give them a competitive advantage. And sometimes that can lead to them or their coaches setting unrealistic goals, trying to achieve the results too quickly, or trying to make these changes during the wrong time of the training cycle. So weight changes, whether it's an increase or a decrease, really should not be attempted while the athlete's in season. That's opening them up to potential injury, especially in the case of weight loss, because a calorie deficit is then not refueling their body adequately, which is really just opening them up to all those problems that we talked about with low energy availability. So weight and body composition are unique to each individual and need to be managed on a case-by-case basis by the sports performance team. So the dietitian, sports medicine team, whether that's team doctor, athletic trainer, physical therapist, that can include the strength coaches, sports psychology. It really needs to be a sports performance team decision to keep the health of the athlete at the center here. And some things to consider are whenever we're developing an appropriate weight or body composition for an athlete would be their sport and their position. Obviously, different positions have different needs. The need for power and endurance, their power to weight ratio, speed, agility, and mobility, and then their current body weight, body composition, and body size. Looking at body composition, it's a necessary tool to develop an appropriate weight range, monitor changes in lean mass, injury recover, and training efficacy. And there are a variety of tools available to measure this, and each has their pros and cons. So we'll go through a couple of them here. You'll see on the left there, the little pinchers are skin fold calipers. The pros of this are that they're cheap and portable. The cons, of course, are that they're prone to incredibly high user error. So I may not measure skin folds the same way that VN measures skin folds or Ryan measures skin folds. And there's a lot of time needed if you're measuring multiple points. So you can do like a 5-point skin fold caliper test, but that's not going to be as accurate as say like a 20-point skin fold caliper test. But then of course that takes a lot more time. And then this is also influenced by hydration status. So as we discussed, 50% of athletes are entering practice dehydrated based on urine specific gravity. So that means 50% of our body composition readings would be inaccurate. The second one is bioelectrical impedance analysis. Sends an electrical current through the body, and that current moves at different rates through muscle and fat, which then helps us come up with a percent body fat. The pros of this, similar to the skin fold calipers, it's cheap, it's portable, and quick. And the cons are that it's also highly influenced by hydration status. So that can be like a 5 to 10% error. So again, highly inaccurate. And then the bod pod, which is the third one, uses air displacement to measure weight and volume, and then is able to come up with a body fat percentage based on that. Pros to that are that it's much more accurate than Skinfold and BIA, but the cons are that it requires a substantial amount of training. Athletes may get claustrophobic because it's a pretty small space inside there, and then it's also expensive. Lastly, over on the right, you can see DEXA, which is dual X-ray absorptiometry, and that is a full body X-ray. So that arm across the top is, the table moves and it is scanning the athlete's full body. And it is more accurate than most of the other measurements up here. So the 3 other measurements that are up here are what are called 2 compartment models. And so they measure just lean mass and fat mass, whereas the DEXA scan is a 3 compartment model. So it measures lean mass, fat mass, and bone mass. And so in doing that, the readings typically trend a little bit higher because we're separating out that bone mass from the lean mass. In those other 3 instances, bone mass gets lumped in with lean mass, which then makes the athletes seem a lot leaner than they actually are. But subsequently, the DEXA is a lot more accurate, and then it also gives us helpful bone mineral density readings. They're not diagnostic, but they can be a good tool for screening and prevention. So the pros to this are that it's, again, much more accurate and it's very quick. It takes about 5 minutes to do a scan. But the cons are that it is, again, very expensive, and of course, training is needed. So this body composition data, it's really helpful as a facet of the athlete's overall fitness and health. So looking at it as part of the bigger picture of their performance can be really helpful. But it is not the only metric that we care about. So the research gives us ranges that many athletes for a particular sport or particular position fall into, but athletes can and do fall outside of that range and still be successful. So as always, athlete health and safety is the #1 focus. What is right for that individual athlete? Always want to be considering that when we're talking weight and body composition. And then the last 2, recovery nutrition. So I kind of talked about a lot of these points up at the top with macronutrients, but I'll summarize them quickly here. So the nutrients that are necessary following a workout are carbohydrate, protein, fats, and fluids. So carbohydrates, we got to replenish those glycogen stores. Protein, necessary for muscle protein synthesis. And again, we don't need it necessarily within that 1 hour following exercise, but want to focus on daily protein intake and getting a quality source of protein with each meal and snack. Fat to help with nutrient absorption, feeling of fullness, and meeting calorie needs. And then fluid for weight maintenance, injury prevention, thermoregulation, and of course, CNS function. And then lastly would be injury nutrition. So our main concerns with injury nutrition are altered energy needs, altered protein needs, any pre or post-surgical nutrition requirements. And so there can be other things that vary depending on the type of injury. So for like a concussion, we may want to supplement with fish oil. For tendon or ligament injuries, we may want to do something like collagen and vitamin C. There's a lot of research coming out about how that could potentially be beneficial. But altered energy needs can be higher or lower depending on a reduction or increase in exertion compared to their initial level. So if you think of like a midfielder for the soccer team that has gone from 3 hours of high intensity exercise to is now in a knee brace walking around campus, that's obviously going to need a decrease in energy needs. But if you have someone like a golfer who maybe had 1 hour of intense exercise a day and 2 hours of low to moderate, who is now on crutches, having to crutch all around campus, to their dorm, to the dining hall, that's potentially an increase in needs. So we would want to touch base with them to come up with a plan for their fueling. Protein needs, this is almost always increased because we know that healing requires an increased amount of protein. And then any pre or post-surgical nutrition requirements that would be dependent on the surgery. But we want to make sure that we're checking to see if the injury was related to low energy availability. It can be, or it might not be, but it's really important to consider, just thinking about all the side effects of red that we talked about earlier. If it is related to low energy availability, we would want to treat the low energy availability and any subsequent deficiencies that came from that, in addition to treating the injury. So our overall goal here is to limit the loss of muscle mass and strength, which is going to be potentially hard to do, but we want to limit it, limit those losses as much as possible. So that's all that I have. So I'd like to open it up for discussions or questions.
All right, so we're going to go down the chat list. If anyone has questions, feel free to type in it. The first one is from Niles, which kind of people are chiming in right now, but his question was wondering how other D1 universities are monitoring hydration. Is this team specific or athlete specific? Alex, do you want to discuss what you guys do over at Delaware?
Yeah, I don't really have too much involvement with it, but from the 4 teams that I've worked with, women's soccer was the only team that actually monitored weight pre and post practice. The other 3 teams I worked with, they didn't actually do anything other than perhaps some education at the beginning of the season.
All right, Katie, can you put up your reference slides again? Karen was asking for them. Thank you. Does anyone have any other thoughts on how their dietitians or their coaches or their athletic trainers look at dehydration, hydration methods? I think, Niles, I think at Wake, field hockey has a certain part of the season where they weigh them, but I think it's day to day, not actually it might be pre and post practice, actually.
Pre and post, yeah. So I guess my kind of question was, we look at our problem kids sorry, during preseason specifically for hydration status, and then throughout the season with football, we do some specific gravity monitoring with a refractometry, kind of pre-practice hydration testing. I was just curious what other ideas I know some people use dipsticks, that kind of thing, for hydration testing, or if people are just still doing pre and post practice weights. I was kind of seeing what else is out there, and then Katie, kind of what best practice may be right now.
So I know that some of the teams that I work with, men's soccer, I think men's basketball, men's tennis, they usually do the weigh in, weigh out method, but they'll do it during like their preseason exclusively. And that's to kind of help, they'll do it for every athlete on the team to help them develop a baseline of what their particular hydration needs are. For a lot of those teams, like men's soccer, if they're doing that in August, that's probably going to be the hottest time of the year that they're training and their greatest hydration needs, because their losses will be greater since it's warm. As far as best practices, I can't speak too certainly on that. I think it kind of depends on the institution and what's available. Urine specific gravity is obviously more effective, but may not be realistic depending on the volume of athletes that an institution is working with. To do that for every athlete once a week even would be a pretty difficult task, I think. So I think the weigh in, weigh out can be a lot more realistic for athletes, and that's been pretty well supported as an effective means of rehydrating. But I don't know if anyone else wants to speak on that for what their individual institution does.
Rich, over at Pitt, you mentioned that it's the RDs and the performance staff that handles it. Do you know what method they use, though? You're still muted.
Sorry. Luckily, my kids are still hiding right now. So we just changed strength staffs over at football. But previously, the football staff, they did urine analysis every day with weigh-ins, and they did post-practice weigh-ins, and then they tracked everything. So we got a report every morning, who lost body weight, whose hydration. I'm not sure what program they used, or what method, and then we got a report and then tied it in with anybody who lost like X percentage of weight or hydration status was below a certain threshold was flagged. And then anyone who had sickle cell was always on the list. So if their stuff was good or bad didn't matter. Like, we always knew what theirs was.
Yeah.
So we just got a new staff, so I'm not sure what program they're going to use.
I think maybe for a lot of programs, doing that kind of initial weigh in, weigh out, and whenever you flag those higher risk, either the heavy sweaters or the sickle cell kids, those could be appropriate populations that then we go on to do urine specific gravity with, depending on staffing availability. That might be more realistic for a lot of programs.
Thanks, Rich and Katie.
So
Go ahead, Ryan.
I think at Duke, typically most of our teams do use the weigh-in, weigh-out method. They serve that time just to collect some other info like RPE that I also know that they track, particularly like on our basketball team. So what that does is it produces basically a green, yellow, or red category. And our dietitian will go in right away, and if somebody's in yellow or red, supplement with some type of hydration beverage. At least that's what I think they do. But it was always an interesting point because you never wanted to punish somebody for being in yellow or red, which I think's, a hard area. You want to educate them and you want what's best for them. But I know that was a big emphasis to not necessarily punish people for being in yellow and red. So I don't know if anybody has any thoughts on.
Yeah, I don't know at Wake if we punish them, but we just make them drink a lot of water right before practice. Luckily, they have like a bunch of meetings before, so they come in the training room, have a bunch of meetings so they kind of get that fluid in, and then we'll recheck those at risk right before practice as they're intake up. Moving on to this kind of concerning this topic though, Niles had asked about managing expectations for weight gains and losses. So not in just the weight cut sports, but like track athletes go through it a lot too. Tim, you mentioned Cincinnati staff, they handle it with a rolling spreadsheet. Do you feel that's been effective with the coaches? Have the coaches bought in, and do you see any barriers to that?
I think you might be muted.
Tim, did you hear the question by any chance? Oh, there you go.
Hello.
Yeah, we hear you.
Okay. So a lot of what we do is similar to what Rick and Niles have both mentioned in terms of the weighing in pre and post. The spreadsheet that we created it sounds really similar to what Ryan talked about, is that it just gives us a visual of what percentage loss are they in. And then typically we practice preseason in the mornings. So we go and we find those people at lunch that are in the yellow and or red and say, hey, listen, this is what you need to do.
Thanks, Tim. And Alex did mention after practices they have hydration coolers with like fluid replacements and meals. We also do that at Wake as well. Just to move the conversation due to time though, I'm gonna move on to the next one. Terry asked, who does DEXA scans and how do they use that information? Maybe Katie, you can start because Wake does it quite often for most athletes.
Sure. So we do DEXA scans every 3 months on every athlete in the department. 3 months is an appropriate amount of time to see changes. If you're doing it more frequently than that, you're probably not going to see a ton of changes. And also, although it's a low level of X-ray exposure, it is additional X-ray exposure for the athletes. So we're doing, the dietitians are the ones that handle that, like I said, every 3 months. And the way that that data is used, so in providing it to the coaching staffs, we don't typically provide individual data because we find that is often not helpful to the athletes' overall performance. So what we'll do is we'll provide a range for the team or the specific position. So like the volleyball team will provide a range for, this is what the whole team's at. We have outside hitters that are in this range, middle hitters in this range, right side hitters in this range, and our defensive players in this range. And we're, depending on the research that's available in that sport, we're often able to come up with a reference range of what is typical for athletes at those positions and playing at a high level. So we can say our outside hitters are in this range, and that's compared to the reference ranges. So we can see that we're within an appropriate range as a group, or we're high or low, depending on the group. And then we go over those results with each athlete individually so that they can understand what it is that we're looking at and what's appropriate, how it can be used, and how they can reach their performance goals based on that data. So we try and individualize it from the athlete's perspective, but then from the coaching perspective, we try and look at the group as a whole.
Thanks, Katie. And I forgot to say, really good job on your presentation overall.
Thank you.
Does anyone else, does your university use DEXA scans continually, and how do you guys know how to use the data? All right, in that case, we'll move on to the next point. Katie, this is probably geared for you since you're well-versed in this, but this is from all three separate questions about supplements in general. It's from Dan Lorenz, Daniel Karam, and also Tony. So the first one is post-op period, like what kind of supplements should they, if they should be using, if not, so amino acids. And then do you recommend vitamin D prophylactically? We'll start with that question first. That's from Dan Lorenz.
Prophylactic vitamin D, we do it on a case-by-case basis depending on lab values typically. We're not normally doing that prophylactically. As far as the post-surgical, emphasis is going to be pretty high on protein. So obviously our protein needs are increased because we've had a lot of trauma to the area from the surgery. We're needing to heal wounds, and we know that that's a very protein, a process that requires a lot of protein. So emphasis would definitely be on that. Assuming that the athlete would have a reduced mobility and decreased activity levels, would look for a decrease in energy needs. And then the increase in protein also, that's going to help. So we're trying to prevent muscle loss and weight loss in addition to healing. And then for a lot of our athletes, we do use a gelatin and vitamin C supplement. So the research is relatively new on this, but basically it says at the very worst, it is doing nothing other than provide additional calories. So collagen it's not on any of the NCAA lists. So we don't use a collagen supplement. We use a medical grade gelatin product, which is rich in collagen. So we're actually providing them a food source of it, which means it's not going to cause any kind of potential problems with the NCAA or positive drug test or anything. So those products are, I believe, enriched with vitamin C, or will encourage the athlete to take it with a source of vitamin C. And we see that the research shows that that collagen can be helpful in rebuilding soft tissues. So particularly following a surgery, that would be very important. And then it's also providing an additional source of protein. So killing a couple birds with one stone there.
Thanks. And Dan wanted to know a better way to put it, he said, was, do you recommend vitamin D as a supplement post soft tissue injury?
We have not been doing that. No, we typically just focus on the protein and energy needs, and then the collagen and vitamin C. So I haven't seen any research related to vitamin D post-operatively, but that may be a gap in my knowledge. So.
Thanks, Katie. And hopefully Daniel and Tony, that covered your questions regarding collagen and the post-operative period. If you guys want to chime in for more specifics, you can definitely do so. Katie, my other question for you is, there's a few Division I PTs on here, and we have those resources to dietitians like you. What's a reliable way to get in contact with dietitians at that network if there's not one on campus or on site? Just because I know all dietitians are geared towards sports. Do you have a resource for everyone?
So are you,
Is there like a directory?
Part of that, are you referring to like a directory, or like just how to get in touch with a large group beyond?
Yeah, more of a directory, like let's say a local dietitian, if they're on a database or anything like that.
Well, the one that I typically use is our main professional organization is called CPSDA, the Collegiate and Professional Sports Dietitians Association. And I know they have a list of full-time dietitians with each university, team, etc. I am not aware of like a public list that they have available, but I believe the Academy of Nutrition and Dietetics has a resource on their website that allows you to search for a particular dietitian in your area. And I think that you can kind of gear it towards specialty as well. So you may be weeding through more kind of clinical and community dietetics, looking at that list, but there should be some sports dietitians on there as well. And then additionally, if you are ever looking for a dietitian and you don't really know where to go, you can always email me, and I can reach out to that network because plenty of people have connections in cities that they might not necessarily be working at a university setting. They might be working in more of a private practice or like sports medicine institute, if that's what you're looking for. So there, I'll put my email address back up. So
I actually sent yours and Ryan's email is visible to everyone too. So
okay, great. Yeah. So
and I'm going to send another email.
I'm happy to reach out. So
cool. Does anyone else have any other questions or anything like that? No? All right. No, this was really good, Katie. Again, thanks for coming on and doing everything. I know you could have probably gone to a deep dive and rabbit hole with all those topics. So we'll definitely kind of take a survey and see if we want another specific topic on it, possibly Reds. But yeah, thanks everyone for joining. I'm gonna upload this and then I'll send out the link so you guys can send to other people to watch it if interested, because we're pretty much at capacity for what Zoom limits for potential signups. Thanks again, guys, and I'll send an email about week 3, week 4 topic and times.
Yeah, and just while we're here, if anybody has any feedback or questions about what the format's going to be moving forward, we'll stay on for now. But thanks again, Katie. Really appreciate it.
yeah, no problem. Thanks, everyone.
All right, see you guys.
Thanks, Katie. This was great.
Nice job, Katie.